Okay, this is the lecture that we didn't get a chance to finish in class last week. We're going to go over immunodeficiency disorders and then into HIV and AIDS. So we have primary and secondary immunodeficiency disorders. So when we talk about primary, there's a couple different types. They can either be acquired, and they're usually acquired by infection of usually a virus. Sometimes it's a congenital or abnormal development of immune cells. We can have combined, which would be T and B cells combined. And then we can have those of just the T cells and those of just the B cells. So we'll break each of those down a little bit more, but the first thing that I want to talk about is the 10 warning signs of primary immunodeficiency disorders, and you can find those on page 359 in your book, but they are the 10 warning signs. Okay, so let's just list them and talk about them a little bit more. The first one is greater than or equal to 8 new ear infections in a year. Okay. The second is 2 or more months of antibiotic treatment with little effect. So if you have someone that's been treated for antibiotics for 2 or more months and no effect, then they definitely could have an immunodeficiency. The third is 2 or more serious sinus infections in a year. The fourth is 2 or more pneumonias in a year. The fifth is an infant's failure to gain weight or grow normally. So they have a decreased weight gain or growth. And when we have a newborn, we do watch very closely for weight gain in those first couple months. So if we would see that they're not gaining weight appropriately, this may be one of the problems. 6 is if we keep getting these recurrent deep skin infections, or sometimes we can get organ abscesses. We talked a little bit about abscesses, and you can imagine if it's on an organ, that to go in and drain that is something even more invasive than if it were just on this skin. 7 is a persistent thrush in the mouth or anywhere else after 1 year of age. Babies less than 1 year of age, especially breastfeeding, thrush is actually not uncommon, but after that, thrush does become somewhat uncommon. 8, so if someone needs antibiotics by IV to clear up infections, in other words, PO antibiotics aren't working for them anymore and they need to be admitted to the hospital and given IV to clear up infection, that's definitely an issue. Nine is two or more what we call deep-seated infections. So infections that just don't go away. Sometimes the patient may become septic at some point. And 10 is obviously a family history. Is there a family history out there of some immunodeficiencies? Okay, so let's break these down a little bit more. We talked about B and T cell combined. Immunodeficiencies. So how does this happen? Well, there's absence of stem cells in the bone marrow. So those stem cells are absent, and this results in a severe immunodeficiency disorder, which we can call SCID. So again, it's severe combined immunodeficiency disorders. So those functional B and T lymphocytes are lacking. And a lot of times this affects infants. So we already know that as infants, their immune system hasn't fully developed. So if they're born with this type of disorder, this SCID, they can easily succumb to sepsis and any other kind of opportunistic infection. Okay, so let's talk about T cell disorders. So T cell disorders basically obviously affect a particular cell, and one of these specific disorders is called DiGeorge syndrome. Okay, so DiGeorge syndrome occurs when T cell angenesis, the T cells don't develop correctly because of a lack of thymus function. So we have decreased thymus function. And this could happen for a number of reasons. The next one that we have is what we call chronic mucocutaneous and this is due to abnormal T cells that can't respond to the candida. So we get, and these are usually infections in the mouth, mucous membranes, things like that. Okay, B cells. So, our B cell disorders would include what we call a selective IgA deficiency. And if you look back in your notes, remember what our IgA does. And this is basically characterized by failure of IgA-bearing lymphocytes to become plasma cells. So therefore, if those lymphocytes aren't becoming plasma cells, we have a lack of that serum and secretory IgA. These people are most often prone to certain infections. And the next B cell one is what we call X-linked, and I'll write it out first before I pronounce it. X-linked A-gamma globulinemia. Okay, so it's obviously congenital. It's an X-linked trait. And the B cells are unable to complete maturation in the bone marrow. So we have a decrease of mature B cells. Remember, go back to your notes if you need to refresh your memory on what our B cells do. So these are what we call our primary immunodeficiency orders. So next we're going to talk about our secondary ones. So secondary immunodeficiency orders. So there's lots of factors that can go into these. Physical, psychosocial, nutritional, environmental, and pharmacological. So all of these factors, they can either singly or in some sort of combination lead to a secondary immunodeficiency disorder. So we're going to talk about 3 different ways that this can happen. So one would be an excessive neuroendocrine response. And this would be to stress, and we would have increased corticosteroid production, which, remember when we talked about stress and adaptation, ultimately decreases our immune system and increases our susceptibility to infection. Okay, second one, certain medications such as cytotoxins and chemo drugs, and we've talked about this too, can cause a generalized secondary immunosuppression. So we know that while chemo kills the bad cells, it can also kill the good. And other medications can also cause certain things like this, like anesthetics, alcohol, steroids, some antibiotics can actually lead to a secondary immunosuppression. And 3 is malnutrition. So this is a major cause of immune system dysfunction. And basically, if we're not getting the nutrition and the nutrients we need, and if you think about someone who's really malnourished, they have lymphocyte dysfunction, altered stem cell development, and all of those things are going to cause an increased risk of infection. So that does it for our immune deficiency disorders. Now we're going to talk more specifically about HIV and AIDS. So we know that HIV and AIDS are 2 separate diseases. Yes, HIV can evolve into AIDS, but people can also live a long time with HIV before it turns into AIDS. So HIV stands for human immunodeficiency virus infection, and AIDS is acquired immunodeficiency syndrome. They are both primary acquired immunodeficiency disorders, and they result in defective immune functioning. The hallmark of HIV infection is what we call, so it's a defective, and we talked about the cell-mediated immunity. And there is especially a decrease in those T helper lymphocytes, or remember we talked about those CD4 cells. Okay, let's talk a little bit about the epidemiology. So we talked HIV is a primary immunodeficiency disorder. It's caused by a viral infection of those CD4 cells. Okay. Yes, it is a major health concern, although our research has come a long way and people are living with HIV for a lot longer now. We know a lot more about it. The long-term prognosis is not excellent. Usually what happens is when HIV progresses into AIDS, a lot of these patients actually succumb to infection or pneumonia, and that's ultimately what kills them. So, HIV is a retrovirus. We talked primarily infects CD4 lymphocytes and macrophages. We see a lot of it infecting people in Central Africa, the US, Europe, and Australia. So we know that HIV is acquired. And it is acquired through, it's a sexually transmitted disease, we know that. Blood products, contaminated needles and syringes. Mom can actually give it to baby through, labor and also via breast milk, although we have had moms successfully give birth, bloodless births to babies when mom has been HIV positive and the baby comes out fine. HIV is known to be present in our urine, saliva, tears, cerebrospinal fluid, and feces, but it's not believed to be transmitted that way. Exposure to blood or body fluids of infected individuals through the skin, mucous membranes, and accidental needle sticks is actually the primary risk factor for healthcare workers. So obviously we need to use universal precautions. If there is ever an exposure, if you have an exposure to someone, bodily fluids, you get stuck by a needle, what happens is we will place people on post-exposure antiviral medications, usually within 72 hours and for 4 weeks after exposure, because it does take a while to get a clear test. So if we talk a little bit about etiology, HIV is actually an RNA virus, also known as a retrovirus. And it must undergo transformation within infected cells in the DNA, or viral reproduction. And what happens is HIV turns the host basically into a virus-making factory. So then it continues to make more and more of the virus. And then what happens is our HIV virus attaches it to the receptor site on the CD4 cell. And it fuses to that cell, it enters the cell, and it changes the RNA into the cell's DNA. And basically what it does is it uses these CD4 cells to damage large amounts of the DNA. And then HIV is released into the blood. And is obviously going to attack other cells. So pathogenesis, again, HIV is attracted to those CD4 cells and T cells. It also likes monocyte macrophages, dendritic cells, cells in the skin, our bone marrow cells, our cervical cells, cells in our colon, duodenum, rectum. It kind of likes them all. Now, when we transition from HIV to AIDS, the hallmark of AIDS is a decreased CD4 count. So you will hear AIDS patients talk about their CD4 counts because we want those counts to stay up. When they get to a significant level, then they are considered to have AIDS. And if you don't have those CD4 cells doing their job, you are going to be ultimately prone to infection. So the hallmark of AIDS is a decrease in these CD4 cells, including those T helper, lymphocytes, and macrophages. And then B cell responsiveness is also decreased because they're somewhat dependent on T helper cell cytokines. CD4 cell death can occur of several mechanisms, and this can involve cross-linking of CD4 receptors by viruses, which may result in T cell death. Apoptosis is also another one. And B cells can start to form antibodies against infected T cells. So again, we talked HIV is an infectious process that progresses to AIDS and is characterized by different clinical stages, and we'll talk about that. And every individual that has HIV moves through these stages at different rates. It all depends on, it depends on the individual, when they're diagnosed, whether or not medications are working. Alright, let's move on to the stages of disease. So basically there's 4 stages from HIV to AIDS, or 4 groups. So the first one is acute. The acute illness. So the phase of acute illness happens in about 50% of patients with HIV. And it usually occurs 3 to 6 weeks following exposure. And it is characterized by, similar to flu-like symptoms, fever, chills, headache, nausea, vomiting, diarrhea, anything you can think of for the flu. Also, a pain in the joints, sore throat, stiff neck, and these symptoms usually last for about 2 to 3 weeks. And then they spontaneously resolve. And why they spontaneously resolve is because some patients actually are developing antibodies to HIV. Okay, so stage 2 is what we call the asymptomatic stage. So asymptomatic, obviously we're not experiencing symptoms, and this can actually last months to years. So you contract HIV somehow, you think you get the flu, the symptoms go away, and then you have this large period of time where you could be completely asymptomatic and not even know that you have HIV. However, the patient during this asymptomatic stage is infectious, so they can pass this disease on. Okay, the third stage is what we call generalized lymphedema. I apologize, it's general lymphadenopathy. And obviously what we have is we have swollen lymph nodes. And again, this can progress. We can go months to years here. So you can see the longer and longer this disease progresses, it's harder to diagnose, especially in, someone who maybe doesn't get normal health care. The fourth phase is the AIDS phase. Okay, so at this phase we get frequent infection, complications, we have numerous clinical manifestations, which are going to, as our CD4 count falls, they're going to get worse. So some of the key characteristics are malnutrition and wasting. Full-blown AIDS patients tend to be very cachectic because they get this elevated metabolic rate, they have chronic inflammation, they have malabsorption, and anorexic and just, multiple opportunistic insults on their body. GI symptoms, again, occur frequently in these patients. Diarrhea, they're really susceptible to cryptosporidium, ulcerations, and again, all sorts of different infections. Pulmonary symptoms. Unfortunately, these patients often succumb to pneumonia or tuberculosis. They can get pneumonia very easily. Basically, a common cold can progress into pneumonia that will ultimately